Hello, and welcome to the latest CSF podcast on axial spondyloarthritis. We'll be bringing you new episodes on a monthly basis alongside our RA and PSA podcasts, and we'll also be supplying you with a monthly slide deck to help you keep up to date with the latest research and publications in the field of axial SPA. First of all, allow me to introduce myself. I'm Sofia Ramiro. I'm a consultant rheumatologist and a senior researcher at Leiden University Medical Center and Zuyderland Medical Center in the Netherlands. And today we have here with us Professor Hideto Kameda, Professor of Internal Medicine at Toho University. And we are also joined by Professor Atul Deodhar, Professor of Medicine and Medical Director of Rheumatology Clinics in the Division of Arthritis and Rheumatic Diseases at Oregon Health and Science University in Portland, USA, as well as Professor Xenofon Baraliakos, a professor for Internal Medicine and Rheumatology at the Ruhr-University in Bochum, and medical director of the Rheumatology Center Rheumazentrum Ruhrgebiet in Herne, Germany. And of course, if you want to find out more about the papers that we discussed today, please head over to the CSF website, www.cytokinesignaling.com. Hideto, over to you, please.
Yes, thank you, Sophia. In the first paper we'll discuss today, the authors compare the efficacy and safety of Bimekizumab with biologic or targeted synthetic DMARDs in non-radiographic axial-SpA and ankylosing spondylitis. Our second paper then goes on to identify distinct clinical clusters based on patient demographics and baseline clinical indicators from the clinical development program of Secukinumab in patients with a variety of rheumatological conditions. Over to you, Atul.
Yeah, thank you, Hideto. Our first paper is titled Comparative Efficacy and Safety of Bimekizumab in Axial Spondyloarthritis, a systematic literature review and network meta-analysis, for which I was the lead author. The background of this study is that axial spondyloarthritis comprises patients with evident radiographic damage or definitive radiographic damage to the sacroiliac joint or ankylosing spondylitis, also known as radiographic axial SPA, and those without definitive radiographic sacroiliitis or non-radiographic axial SPA. AS and non-radiographic axial SPA share a similar clinical presentation and disease burden. Despite available treatments, many patients do not achieve a sufficient treatment response or partial remission, and some lose their clinical response to treatment over time. Bimekizumab is a humanized monoclonal immunoglobulin G1 antibody that recently received marketing authorization in the EU and in the UK. Bimekizumab selects for IL-17F in addition to IL-17A, and it inhibits both of these pro-inflammatory cytokines, which are key mediators of inflammation and new bone formation, which can lead to structural damage in axial spondyloarthritis. This network meta-analysis aimed to establish the comparative efficacy, safety, and tolerability of subcutaneous Bimekizumab 160 mg every 4 weeks versus biologic DMARDs as well as targeted synthetic DMARDs in axial spondyloarthritis. So we conducted a systematic literature review identifying randomized controlled trials until January 2023 for inclusion in a Bayesian network meta-analysis, including 3 biologic and targeted synthetic DMARD exposure networks. Patients who were predominantly naive, or those who were completely naive, or those who were experienced. And the outcomes we looked at were ASAS 20, ASAS 40, and ASAS partial remission response rates at 12 to 16 weeks. A safety network meta-analysis investigated discontinuation due to any reason and serious adverse events at 12 to 16 weeks. So here are the results. The network meta-analysis included 36 trials. The predominantly naive population of patient network provided the most comprehensive results. In the predominantly naive non-radiographic axial SPA analysis, Bimekizumab had significantly higher ASAS 20 response rates versus Secukinumab, 150 milligram with loading dose or without loading dose, and comparable response rates versus all other active comparators, including Ixekizumab, the other IL-17A inhibitor. In the predominantly naive AS ankylosing spondylitis analysis, Bimekizumab had significantly higher ASAS-40 response rates versus Secukinumab, 150 milligram without loading dose, and significantly higher ASAS partial response rates, partial remission, I should say, ASAS partial remission response rates versus Secukinumab with load, and comparable response rates with other active comparators. Bimekizumab demonstrated similar safety to other biologic DMARDs and targeted synthetic DMARDs. So in conclusion, across the ASAS outcomes that we looked at in this study, Bimekizumab was comparable with most biologic disease-modifying antirheumatic drugs or targeted synthetic DMARDs, including Ixekizumab, TNF inhibitors, and upadacitinib. Against Secukinumab, it achieved higher response rates to some of the ASAS outcomes in predominantly biologic and targeted synthetic DMARD naive non-radiographic axSpA and AS patients at 12 to 16 weeks. In a pooled axSpA network, Bimekizumab demonstrated comparable safety with other biologic and targeted synthetic DMARDs. So that's our paper, and I would like to open it for discussion.
Thank you very much, Atul. I think it's very good to have this first presentation by you, and now to open it indeed for discussion. Maybe I can start, and I would like to hear your opinion of what you think to do this type of, I would call them methodological exercises with a bit of data. Do they replace real head-to-head studies? Or to what extent are we getting or not getting further than what we already had with placebo-controlled trials?
Yeah, so that's a great point. I mean, I think it gives you some indication as long as you understand, and you kind of hinted it in your question, is that head-to-head studies are the best. Unfortunately, head-to-head studies are very expensive. The drug companies are understandably worried of doing head-to-head studies because their drug might come, I mean, it may not really show as much improvement on the existing competition that they have. So these are the types of things which give us some idea. And this actually, we did go to a great length, I should say, to come to this conclusion that only in certain people, mostly biologic DMARD naive population, and only against one IL-17 inhibitor, Secukinumab, some of the outcome measures were better. And if you think about, if you really did a head-to-head study of Secukinumab versus Bimekizumab, you're going to require huge number of patients for a very long period of time. This gives you an indication that it's not going to be that easy. Overall, I think it is kind of an exercise which tells us that this drug is as good as, and maybe slightly better than something, but not really dramatically better. Comparative effectiveness is, of course, extraordinarily important. Several of the national organizations and nations want to really reduce healthcare expenditure. So this gives us some indication. And I take your point, what you are hinting at, that head-to-head studies are great, but in the absence of those, this is one of the indirect comparison.
Yeah, I think this is a good discussion, and I like to hear your point of view. I have to say that I am a bit worried with this type of exercises, because I understand and I agree with the reasons you gave for which they are done. Head-to-head studies cannot be easily performed. But then, is this really giving us an answer? So now, if you were UCB, would you put your money in a head-to-head study with Secukinumab? Do you really believe that? Or then it's better to not put because we don't believe. And if we don't believe, are we really moving forward with this type of exercises, or are they somewhat artificial? I think we have seen in the past this type of exercises done, supported by different companies on different drugs, and depending on the company supporting, then the results go in one direction or the other. And that makes me suspect about this type of exercise. So I think it's good to have this discussion amongst us, open discussion. I think you understand where I'm coming from.
Completely. I mean, just one quick point. There's another, since we are doing this discussion and other people who are listening or who are attending our podcast, there is this MAIC, matched adjusted indirect comparison, and you know about this. Match adjusted indirect comparison is another way of doing this particular comparison. Also has its own problem, but there you try to at least match the baseline characteristics, but then of the Secukinumab study, so for example, versus Bimekizumab study, because in network meta-analysis, there is no way of matching. The baseline characteristics are very different. The problem with matched adjusted indirect comparison is that the number of patients reduce dramatically because you don't to match them. But that's another way of sort of doing this indirect statistical exercise, trying to find out which drug is better in absence of head-to-head studies.
Thank you. I'm curious what our other colleagues think about these methods and then these conclusions. How do you take them to your daily clinical practice, Xenofon and Hideto?
Yeah, for me, it's very difficult to completely matching every findings and also some characteristics because we do not know everything about the baseline characteristic or something. So we need some more sophisticated or other methods to conclude a very firm conclusion. And also, I wonder, how do you think about the predominantly naive patient versus experienced patients?
Yeah, I'll quickly answer that and then let Xenofon speak. So when you're doing network meta-analysis, you're trying to compare various studies, and every drug is compared to the placebo. And several studies we discovered actually had patients who were biologic naive, and 20% patient, 15% patients were biologic experienced. And it is sometimes difficult to tease them out. And that's why we then decided we are going to do purely naive. There are some studies in nr-axSpA, purely naive, biologic DMARD naive population. Some are purely experienced and some are these. And in the other two, the purely naive, and there were less number of studies to do really a network meta-analysis, and there were even lesser number of studies which were looking at purely experienced. So we could not come to any conclusion in the experienced population. So we did look at that, and it wasn't enough number of patients to really do a good statistical analysis. So that question remains open.
Okay, thank you.
Last comments from Xenofon on this paper before we move forward?
I don't have any other comment. I think you summarized it all very well. There's pros and cons for everything we're doing. This will never obviously replace a head-to-head trial. We may be getting some kind of signal, or at least see if what we sense from the raw data may be also found in such meta-analysis. But of course, we all have learned that this is not something we would really take into account if we have to prefer one drug over the other. But on the other hand, it's interesting to see different opinions. So I don't see people should stop doing them. They will not anyway, but it's not a head-to-head trial. That's the important thing to see.
Yes, thank you. I think we can move forward to the next paper. So over to you, Xenofon.
Yeah, thank you. So we can all go over to the second paper that is entitled Patient Clusters Identified by Machine Learning from a Pooled Analysis of the Clinical Development Program of Secukinumab in psoriatic arthritis, ankylosing spondylitis, and psoriatic arthritis with axial manifestations, for which I was also the lead author, but this was, of course, a joint effort. So the study background is such that we do not have any universally accepted classification criteria for the definition of axial psoriatic arthritis, nor is there any consensus on that yet, we have to say. On the other hand, we know that machine learning techniques can investigate the patterns from large clinical data sets and identify distinct clusters of patients with potential therapeutic or prognostic significance. And this, of course, may lead, and that's the ultimate goal, to a better understanding of the disease, and also bring us forward towards precision medicine if possible. So the objectives of this post-hoc analysis were to identify distinct clinical clusters based on patient demographics and baseline clinical indicators from the Secukinumab clinical development program in patients with psoriatic arthritis, ankylosing spondylitis, or radiographic axial SPA, as Atul also mentioned, and PSA with axial symptoms and manifestations, and further supports also the characterization of the axial PSA phenotype within a spectrum of spondyloarthritis. What did we do? We pulled baseline demographics and clinical data of Secukinumab treated patients from phase 3 studies, 10 overall, from the indications of PSA, the future 1 to 5, and maximize, and studies with ankylosing spondylitis, measure 1 to 4. And they were analyzed by machine learning algorithms. The longitudinal responses of Secukinumab 300 milligrams versus 150 were investigated across the clusters and across 3 clinical indicators of tender joints, swollen joints, and enthesitis. The underlying assumption that we had was that if 2 patients belong to the same cluster, then their clinical measurements across different binary variables share similar multinomial distribution. It might be a little bit difficult to understand, but you will see how we came up to the results we came up with too, and that is something that then one can go back and understand the methods behind that. The clustering algorithm was applied repeatedly on different subsamples of the patients to assess clustering robustness and stability. So we really tried to find different phenotypes that patients may belong or not belong to the different diagnoses, you may say. So for the results, we had almost 4,000 patients, 3,907. They are grouped into 8 distinct clusters based on patients' demographics and baseline clinical characteristics. Patients with psoriatic arthritis and axial manifestations from the maximized trial were overrepresented in different clusters, number 6 to 8. Patients in cluster 6, they had a mean age of 48 years and they were almost 50%, this is 46% male, were overweight with pronounced psoriasis, high articular burden in knees, shoulders, elbows, and wrists. Patients in cluster 7, they were mean age 47 years and 53% were male, were less overweight with lower polyarticular joint count and tenderness of the joints of the feet, wrists, and hands. And patients in cluster 8 were predominantly with AS diagnosis. They had a mean age of 43 years, 64% were male. They had a mean body mass index of 27.3, and they had oligoarthritis, and they had a prevalence of spinal pain. Patients with PSA from the future trials were overrepresented in the other clusters, 1 to 5. And the longitudinal analysis showed improvements in Secukinumab 300 milligrams versus 150 milligrams in clusters 6 to 8. For tender joint count, clusters, and in cluster 7 for swollen joint count. Altogether, what did we learn from this complicated analysis? We learned that PSA clusters are there. They may be obtained by a more detailed analysis that can be done by machine learning in many patients from pooled data sets. And they indicate phenotypical heterogeneity of patients with PSA and axial manifestations and overlapping features across the spondyloarthritis spectrum. And this can be seen by different ways of having the clinical appearance. This means either the bigger root joints or the smaller peripheral joints or the spine. And this is, of course, also important, and I may also open the discussion with that. This is important because, remember, these patients that we put in here, they were coming also from both from the PSA and from the AS field. This means we need to have enough opportunity with many patients to analyze both peripheral and axial symptoms.
Okay, thank you, Xenofon. So my comments is when the patient receiving Secukinumab 300 milligram, then no big difference was observed among 8 clusters. But when using 150 milligram, some difference was observed in the clusters. So how can you explain the reason?
Well, I believe it's pretty straightforward, and I would like to make a parallel here, which is not very good in terms of the efficacy, but still for the concept is maybe important. Remember also the data we have obtained from patients who have been treated with TNF blockers and methotrexate in ankylosing spondylitis. Yeah, we know methotrexate doesn't lead to anything, have any efficacy, but still those patients who were receiving CS, DMARDs, and mainly methotrexate showed somewhat better responses and also longer drug survival. This means if you cover more anti-inflammatory activity by any means, this might obviously lead to an overall improvement of symptoms. And I believe this is what is happening here as well. So we give more drug, we get more patients into a, let's say, even the smaller issues that the drug may cover. I still do not believe that 300 milligram of Secukinumab is the one and only way to go. 150 milligram is enough as well, but there might be more patients you capture with the 300, and this gap between those two groups is the one that I would indeed then go over and increase the dose for.
Thank you. Sofia, any comments?
Yes, I had a comment, a question or a comment about the clusters. The fact that we see that patients coming from the Maximize trial, so patients with PSA with actual involvement, cluster mostly in clusters also that in which we find patients with actual SPA. So are we seeing there an overlap in the phenotype, or do you believe more in two different entities? Where is this pointing us towards? I like controversial questions, as you can see.
Well, I think that's the question of that whole analysis. And to be honest with you, we cannot answer that yet. I think we'll learn from these studies, not only the Maximize trial, but also the other post-hoc analyses that have been done in axial PSA, or what we believe is axial PSA. In Maximize, you may remember, we didn't have an inclusion criterion of imaging. No. It was purely the physician who said there is inflammatory axial disease in a patient primarily diagnosed with PSA. So I do not deny that there might have been patients who have ankylosing spondylitis plus psoriasis, but for some reason PSA was, or psoriatic arthritis, but for some reason PSA was firstly defined, and thereafter the axial skeletal was looked at. So, but by the way, on the other hand, there were differences in the clusters. You may remember there were more females in the axial PSA, purely axial PSA, more males in the AS. There was more peripheral involvement in the axial PSA, this is cluster 6 and 7, as compared to cluster 8. So I do believe there is a difference. How big that difference is and how well we can define it for future clinical trials in axial PSA overall, we need to understand. This will be obviously seen hopefully next year with the AXIS trial.
Yes.
Yep. Yeah, quickly. I think Xenofon summarized it, that there is a difference between these clusters, but it is small difference. And I was kind of thinking when you were presenting cluster 6 and cluster 7, one is 48 years and one is 43 years or 47 or something, kind of very small differences. And one is overweight, but one is not so overweight. I mean, thinking in my clinical practice, when I'm seeing a patient and I need to decide which drug should I be choosing. I mean, ultimately, if you take a step back, the reason why the machine learning and these clusters are important is we are hoping that we will be able to find out baseline characteristics, clinical parameters, phenotypes, which are distinct. And then we can then say that this particular drug works better in this particular cluster or with patients with this type of baseline characteristics. And here the machine learning is kind of, it is differentiating patients, but they're pretty overlapping. They're not very, very distinct. And so currently, I think this is interesting, and this probably will get more and more sophisticated. I don't really think that this is ready for my clinical practice, that this particular cluster, if I have, then I'm going to use Secukinumab 150 milligram or 300 milligram or whatever. It's that's the way I look at it. These are early steps with machine learning, trying to differentiate, find out a small sliver of patients where particular drug will work the best.
No, I fully agree. We need to understand that artificial intelligence right now is only helping for very minor parts of what we're doing. I mean, I was discussing today with our radiologists about their future overall with machine learning, and they've simply said, well, we're by far not there yet. You have perfect algorithms to identify, let's say, meniscus tear, but what else is happening in the knee you don't have. So while you would be better in meniscus tear differentiation from other pathologies by machine learning, the machine will never be able to tell you if there is anything else that is wrong in the knee. That's why, indeed, we're looking into very little pieces of information. I think we will, I mean, these are all pieces that may come together at some point, but so far we're able to understand very little parts of what's happening, and that might be a start of it by thinking of why not differentiate differently in the next step of a clinical study. By the way, we should not forget these are post-hoc analysis. So we have already a selection bias, and that is something we will never get rid of unless we do something prospective.
Okay, thank you. Now, Sofia, please close today's session.
Yes, I think it's time to closure. Thank you all for joining us for this axSpA podcast, brought to you by the CSF. We really hope you find it useful. If you did, don't forget to subscribe to our channels on YouTube, SoundCloud, Spotify, or wherever you get your podcasts from, so that you don't miss any future episodes. And if you want to read more about what we have discussed today, head over to the cytokinesignaling.com, where you will find the summary slides of both of these papers presented. See you next time.